All right. Oh my goodness, it's so amazing being here. Thank you, Karen, for giving me the opportunity. And I hope we one day get to treat cancer, not to treat it, but cure it. And but today we are so much improving with therapies. Patients live longer with a better quality of life. I have also an accent. This presentation is about immunotherapies, which is the latest generation on treatment, treating cancer today. And I think it's amazing how our patients live longer with better quality of life, like I mentioned before. Some of the things that we'll be touching today would be immunotherapies and some of the modalities that we use to treat cancer. I heard somebody said long ago that there are more people living today than they have ever died. I didn't believe that, and I searched it, and it's true. So that's what cancer treatments do today, especially immunotherapies. Some of the cancer modalities that have been used to treat cancer include surgery, radiation therapy, external and internal radiation, chemotherapy, and that includes our biological or immune therapies and clinical trials as well as the alternative therapies. To better understand immune therapies, we have to speak about the immune system, and I like to use Dr. Avi ad principle of what is the immune system. The immune system is the police that patrols our streets, and it keeps us from, safe of diseases and infections. And I'm sorry, I'm a little nervous. Let me see if I go back here. It's like the police that goes on the streets and then keeps check of everything that goes into our body, all the elements that are in our body, anything that behaves differently, anything that has any cells that has been infected or behaves differently. The immune system recognizes that, and then it tells it to die or self-destruct. And that's how the immune system works. The latest research has found therapies that actually use the immune system to help and kill the cancer cells. So these are cancer modalities. So how the immune therapy works. Immune therapy uses certain parts of the immune system to attack cancer and to kill cancer. So it could be by boosting the immune system or making the immune system stronger to kill the cancer cells. The immune checkpoints are molecules that are found in certain immune cells that need to be activated or inactivated to begin an immune response. And this helps the immune system this helps the immune system distinguish between cancer cells or foreign cells and normal cells. But cancer cells, like Dr. Avi says, they use a fake ID. So some of the cancer cells can produce cells or produce substances that actually keep the immune system in check. So a cancer cell to grow needs time, and it needs to not to be recognized by the immune system, because otherwise the immune system will kill that. So it makes molecules that keeps the immune system in check. So the immune system does not recognize it and kill it. These immune checkpoints are PD-1, PD-L1, and CTL4. These are proteins that are in the immune system, in the immune cells. PD-1 is a T cell. PD-L1 is a protein that it exists in some normal cells and also in cancer cells. The CTL4 is also a protein found in some of the cells that acts as a switch off to keep the immune system in check. Therapies that target these immune these immune checkpoints bind to block the binding, and then against the therapies that target these immune checkpoints can block its binding and boost the immune system response against cancer cells. The PD-1 inhibitors are the Keytruda, the Opdivo, and the Libtayo, and these drugs are being approved to treat non-small cell cancer, kidney and bladder cancer, head and neck cancers, and Hodgkin's lymphomas. The PD-L1 inhibitors are the atezolizumab, avelumab, and durvalumab. These drugs are being used to treat bladder cancer, non-small cell cancer, as well as Merkel cell carcinoma. The CTLA-4 inhibitors are the ipilimumab, or Yervoy, and tremelimumab is an investigational drug that is a monoclonal antibody that blocks the interaction of the CTLA-4 checkpoint. Some of the approved indicators that we mentioned before for these therapies are the metastatic melanomas, the first line and second line for non-small cell cancers, some of the head and neck cancers, Hodgkin's lymphomas, urothelial carcinoma, and also renal cell cancers. Some of the considerations that we keep in mind as nurses, oncology nurses treating these patients on immune checkpoints inhibitors are that these medications can actually allow the immune system to attack normal organs in the patient's body and our bodies. So it's important to recognize these symptoms and know these adverse events, as well as measure their toxicity or grading their toxicity. Early recognition of the symptoms and prompt intervention of the symptoms can allow the patient to receive more therapy and therefore lessen the side effects and continue with the therapies. The higher the grade are these adverse events, the worse a patient will do with the treatment, because that means that we either have to interrupt the treatment or discontinue the treatment completely. And that's not the goal for these therapies and for us as providers. The NCC recommends guidelines to assessment for the patients when are to be receiving one of these immune checkpoints inhibitors. And it's important that the patient, before receiving the treatment, of comprehensive assessment is done. And this is for our doctors and practitioners. The patient should have a comprehensive clinical assessment that includes physical examination with history of any autoimmune diseases, including infectious diseases, blood work, imaging, CT scans, MRIs, dermatological examination, thyroid. It's important to know the thyroid, any thyroid disease on our patients prior to beginning treatment, adrenal and pituitary, pulmonary assessment, all the PFTs and oxygen saturation, cardiovascular assessment, as well as musculoskeletal assessment. This is all before patient starting treatment, and then the monitoring and the frequency of that should be done accordingly and repeated every 6 to 12 weeks or every 2 to 3 weeks accordingly. This table shows some of the immune-related adverse events for each of the checkpoints inhibitors, and distributed in grade 1 and 2's immune reactions, immune-related adverse events, 1 and 2, and the second, the table B shows the distribution graded 3 and 5. So most of our patients experience grade 1 and 2 of the adverse events, and for the CTLA-4, CTLA-4, which is the ipilimumab. It shows a graded percentage of our patients reacting, having skin reactions as well as gastrointestinal reactions. A little bit lessened, but again higher on the PD-1, the Keytrudas, the Opdivos, and the other treatment, the PD-1 inhibitor, is the skin reactions as well as GI reactions, and a little bit of arthralgias as well. And the distribution for the grades 3 and 5 immune reactions, adverse events, it shows a higher grade on the ipilimumab as well, not so much on the PD-1 and PD-L1. Endocrine and gastrointestinal for grade 3 and 5s. These immune-related toxicities are is the way to manage for the different toxicities. The first, these slide is for skin toxicities, and this is for our doctors and practitioners. For grade 1 and 2 skin adverse events, the therapy should be discontinued for at least a week and then continue with the immune therapy. Start topical emollients, antihistamines in the case of pruritus, and or topical corticosteroid. For grade 3 skin adverse events, we should interrupt the therapy and begin immediate treatment with topical emollients. For grade 4, the discontinue of the therapy should occur permanently, and then consult a dermatologist. The endocrinopathies, this is the hyper and hypothyroidism that they can also occur. For grade 1 and 2, the therapy should be interrupted and begin any beta blockers in case of hyperthyroidism. Reinitiate when the symptoms subside. In case of hypothyroidism, grade 2, begin hormone replacement therapy. If thyroiditis, which is an inflammation of the thyroid, we should begin prednisone orally 1 milligrams per kilograms and taper down. If hypophysitis occur, which is an inflammation of the pituitary, when headache or diplopia or any other neurological symptoms occur, prednisone is a treatment, 1 milligrams per kilograms orally, and taper down. Begin hormone replacement therapy depending on the affected hormonal axis also for the thyroid. And in patients with type 1 diabetes, grade 3 and 4 ketoacidosis, admit the patient immediately to the hospital. Immune-related hepatotoxicities for grade 2 hepatitis, withhold the therapy and monitor the liver function levels. If no improvements over a week, then begin the prednisone. For grade 3 hepatitis, discontinue the therapy immediately. For grade 4 hepatitis, permanently discontinue the therapy and admit the patient to the hospital. Gastrointestinal toxicities in patients with grade 1 diarrhea. ICP can be, the therapy can be continued, but monitor the patient closely with antidiarrheal medication. In grade 2 diarrhea, interrupt the medication and begin corticosteroids. If no improvements within 3 to 5 days, colonoscopy should be performed to rule out any colitis, so the patient can benefit from RMK or any tumor necrotic factor inhibitors. If severe diarrhea occurs 3 and 4, permanently discontinue the therapy and admit the patient to the hospital. Pneumonitis is inflammation of the lining of the lung. In grade 1 and 2, hold the therapy and rule out any infections and begin prednisone. In grade 3 and 4 pneumonitis, discontinue the therapy permanently and admit the patient to the hospital. It could be considered adding Remicade and or any immunosuppressive therapy for in case of deterioration from patients receiving too much corticosteroids. Neurological toxicities include in the event of neurological adverse events, withhold the therapy and perform MRIs or scan to rule out and define the etiology of this toxicity. If deterioration occurs, the patient should be admitted to the hospital and begin immediately the prednisone 1 to 2 milligrams per kilograms orally or IV. Guillain-Barré or myasthenia gravis symptoms occur, considered adding plasmapheresis IV or IVIG. A cardiac toxicity, if myocarditis is suspected, admit the patient and immediately begin high dose of prednisone again. So in the event of deterioration, consider adding immunosuppressive therapy. For rheumatological toxicities, mild arthralgias begin non-steroidal medications, and if no improvements, consider low dose of steroids. In severe polyarthritis, refer the patient to a rheumatologist. Remicade and another anti-necrotic factor drug may be required to improve the inflammation symptoms. For renal toxicities, in case of nephritis, rule out other causes of renal failure first. Then interrupt or permanently discontinue the therapy. Stop also other nephrotoxic drugs and consider renal biopsy. So because we see all these side effects that can occur to a patient with this wonderful therapy that not cure people today, but definitely let them live longer with a better quality of life. We see patients coming into the treatment area, either coming from work or going to work after treatment. It's only a 30-minute infusion. The longest is a one hour infusion. The patient just come, get an infusion done, no losing hair, no having stuff in their hair because they're bald, not having nausea, fatigue, or any issues whatsoever. So they can get into their car and they drive home or work, and they continue their life. Best ever happened. So it's important that these patients and the families, which is the greatest support that they can have, and an example is Jay, that we saw him coming into the treatment area with his wife all the time. It's amazing. To receive the best education ever, up-to-date education and timely. Is before the treatment, throughout the treatment, and even after survival, because side effects can occur at any time after the patient begins therapy. So it's important that the education continues. We nurses in the oncology treatment area, infusion area, we spend more time with the patients than anybody else outside, the doctors or anybody. So we get the chance to talk to them continuously, and reinforce of the side effects and how should they manage them. Most important is to tell the patients that any time that side effects occur, diarrhea, any coughing, any shortness of breath, any dizziness, any skin issues, any pruritus, anything, after the therapy has begun, they need to tell the doctor right away. It could be a sign, it could be a side effects that if it's not noted and if it's not treated on time, it can escalate, and therefore the patient next 2 or 3 treatments can be discontinued and no benefits whatsoever. So it's also important to continue education as well as tell the patient how to keep infections controlled, safety, sexual behaviors, as well as medications handling. It's important to follow the doctor's prescriptions and continue practicing safety and proper handling of medications and infection control. I'm sorry, I'm repeating myself. To support these optimal management of the adverse events, the Oncology Nursing Society has an Immunotherapy wallet card available, which I forgot to bring some with me, but I have a copy in here, and you can get this actually via the website or email at clinical@ons.org. And the wallet card is very, very, very handy. It actually has 2 parts. The first part, you put the patient's name, the cancer diagnosis, and the agent that the patient is receiving in case you check checkpoints inhibitors or however it is, monoclonal antibodies, oncolytic biotherapy, however, the medication's name, the immune therapy, when did it started, and other cancer medications. These the patient carry with them, because the patient may have started immune therapy yesterday, and a week later, he's not coming again to our center, but he started having diarrhea or having some of the issues, and they decided to go to the ER. So they went to the ER, and the doctors in the ER don't know what the patient is receiving. They said, oh yeah, I have cancer, and I'm receiving chemotherapy. So the doctors don't know, and they may treat the diarrhea with hydration and Imodium, and they send the patient home, and the patient goes home and continue having diarrhea, but they don't want to go back to the ER, so they have diarrhea, 3 to 4 diarrheas, 5, 6 diarrheas, and they dehydrate themselves, and they get to the point where they come to us and they already dehydrated, so we have to suspend the therapy until the patient gets better. So that's what we're trying to avoid. So with this monitoring. If the patient carries the immune card with them, with the patient and the family members are aware that they should go to any other doctors and tell them, I am receiving immune therapy. This immune therapy can cause organs to fail in my body, so therefore I can have this and this and that. Then they know how to treat them and properly address them, and then the patient can go home, feel better, and then continue receiving the treatment. So that's why it's important that the patient and the family receive the education properly. And for our conclusions, the cancer is a difficult subject. We know that. It doesn't matter how old we are or what gender we are or what religions we believe or cultural. It's always difficult for anybody. But today, the treatments that such immune therapies are making the patient live longer and with better quality of life, which is the goal, and which is what we always wanted to see in our patients. And that is achieved only by good education and proper assessments and monitoring of our patients. Also including all the disciplines available for the patients and the family and the families and caregivers and caretakers. The nutritionist is important. The social work is also important. The psychosocial is also important. So including all these disciplines in the patient care is as important as it is seeing the doctor, getting the blood work, getting the MRIs or PET scans done, as well as the immune therapies or whichever therapies. Any questions? Thank you.